Okay. Yeah, the numbers are still creeping up, actually.
Yeah.
Well, great. Okay. Hello and welcome to BioConnector 2021. And this long demo session. We'll start the talk shortly, but first a few housekeeping items. If you have questions for the speaker, please enter them in the Q&A tab. You also have the ability to upvote questions for the speaker to answer. If you would like to ask your question live, please use the raise hand feature and the moderator will bring you on stage. There are a variety of emoticons available to give feedback to the speaker as well. And if for some reason you have to leave early, a video of this session will be available a couple hours after the session has completed. And now let me introduce you to our speaker. Chloe Anya Mirzayi is a data scientist at the Institute for Implementation Science in Population Health at CUNY. She works on a variety of projects on topics related to, for example, COVID-19, microbiome, HIV, drug and alcohol use, and sexual health. Her research interests are focused on the role of the microbiome on human health, causal inference in microbiome research, and the effect of public opinion and social media on public health. So yeah, I think you could start the presentation.
Okay, great. Good morning and good afternoon or good evening, wherever you are. Hi, everyone. Thank you so much for attending this presentation. And thank you, Michael, for that excellent introduction. I am sharing my screen now. You should be able to see the workshop materials. If you would like to follow along on your own, it's available on my website. I believe it's also available on the conference website somewhere, but I will put it in chat just in case you want to follow along on your own. And with that, I will just get started. I just want to say, if you have any questions, comments, if you, as Michael said, want to ask your question kind of verbally or live, feel free. I want this presentation to be interactive. And I think often some of the best parts of this talk have been some of the really interesting and amazing questions I've gotten from people. So we're going to get started by thinking about probably the most famous causal inference problem, which is smoking and lung cancer. Today, we are pretty sure, I think most of us are pretty sure, that smoking causes lung cancer and that there isn't much doubt about that. However, it was very controversial in the 50s and 60s. There was a lot of back and forth. You can actually go back to some of these old journals from that time and read just the debates they were having. And one famous statistician, R.A. Fisher, whom you might have heard of, he developed ANOVA, F distribution, Fisher's exact test, etc. So just a very big name in statistics. He believed that smoking did not cause lung cancer. And he died with that belief. He was also an avid smoker, and I believe he took money from the tobacco industry, but he argued that correlation does not necessarily mean causation, and that even though they were doing these studies and finding just that so many people who were smoking were developing lung cancer later in life, that this relationship was not causal. So I bring up this example because I want you as people attending this workshop to think about two questions during this talk. If you wanted to prove Fisher wrong and demonstrate that smoking causes lung cancer, how would you do so? I think, there's obviously the answer of doing an RCT of smoking, but you might have trouble getting that past an IRB right now of us randomly assigning people to smoke. And the second question is, one of Fisher's main arguments was that there must be a genetic factor, and this genetic factor was correlated with both people smoking, so this genetic factor caused people to smoke or smoke more, and this genetic factor was also causing lung cancer. And he argued that this genetic factor was what was truly causing this observed relationship between smoking and lung cancer. How would you test this theory? And feel free to ruminate on these questions. If you have like a eureka moment, you can post that in the chats or the Q&A. But I think this is a motivating set of questions. So I'm going to talk today about causal inference, about how we as researchers and scientists can improve how we answer causal questions. I'm going to try and avoid the very difficult math and theory behind this. I will give some follow-up materials at the end that if you want to learn about all the math behind this, you are welcome to, but I want this to be a gentle introduction. And I will try and introduce concepts without too much jargon, and hopefully this will be at a beginner's level. But if you need any help, if anything I'm saying is not clear, again, just put the question in the Q&A. And so my first question that I want people, if you could chat this or Q&A this, maybe chat it, in your own words, what is a cause? What does it mean to cause something? And feel free to share your answers. This is one of those questions that I think is I don't know, I think about sometimes and think this is not always an easy question to answer. So whatever comes to mind, just feel free to chat it. I'll give you a minute. Okay, we've got a couple answers coming in. Michael says, if you can toggle it off and on, you would see a difference in outcome. That's a great answer. It's very much the RCT, the randomized clinical trial, answer. Like, okay, well, if we, kind of intervene and change it in some way, we should see a difference. To directly influence the probability of an event occurring, yes, so it definitely changes the probability of something occurring. Either increases or decreases it, causes it or prevents it. A source of change. B happens followed by a direct effect from A. Yes, these are all good answers. A factor or variable that influences a phenotype. Yes, yeah, exactly. Something that changes something. Yeah, these are great answers. So these are good answers, and I think you're actually getting at the point, which is that it's something that brings about some kind of change, an effect or a result, whether that's a change in the probability of something occurring or actually just causes that event to occur or to not occur. These are good answers, and I sometimes find it difficult to think about causality in terms when I'm thinking about very small things, but I think actually humans, we tend to have a very good understanding of causality and causal inference, because I think about when I was putting this together, I was cooking dinner once and I burned my finger, and I knew what caused it, my finger coming in contact with a hot stove. And then I could, kind of think about this causal pathway, like what happened that caused me to be distracted while cooking to make me touch this hot stove. Well, I was distracted by my cat, or maybe the recipe that I was making was very difficult and I was trying to figure out what I was doing and I wasn't paying attention to where my hands were. So we can trace back causal paths in our real life, pretty easily, but then what's harder is doing this in the context of our work. And so my follow-up question, and again, feel free to put these in chat, what are some causal questions we may be interested in within the context of bioinformatics or your field of work, study, or research? And feel free to put those in chat, but I'm gonna move on because I just want to cover everything. But that's something to start thinking about, like what are the causal questions in your work? So the nature of our work, I think, is that we don't usually directly observe causal pathways. We don't usually see the equivalent of people putting their fingers on hot stoves. We can't watch the in real time the genetic variant cause the disease, or the microbiota causing some kind of problem in the gastrointestinal system. So rather than, having some vague definition of what a cause is, we have this great definition called the counterfactual definition of a cause. And that is defined as, and I'll read this verbatim, what would have happened had the event of interest, had the exposure, what would have happened to the event of interest had the exposure not occurred. I think that's a little confusing and a little wordy. So let's consider a very concrete real world example. And my example is a dog in an ambulance. So if we imagine, late at night, I lived in New York City for a decade, so there was a lot of ambulances, and lots of random noise in the middle of the night. So imagine an ambulance, it drives by your house with its sirens on, and a dog in the house's backyard starts to bark. And we can ask this causal question in kind of a straightforward way. Did the ambulance driving by the house cause the dog to bark? But then we can rephrase that question in the counterfactual definition. Would the dog have barked if the ambulance had not driven by the house? This kind of forces us to imagine a world where this counterfactual world where this ambulance did not drive by the house. And so we're kind of playing this what ifs kind of Star Trek alternate reality game. But what that allows us to do is kind of focus in on, what is the causal mechanism here, and to try and answer that question. We'll explain how we can answer that question a bit later. And so we can rephrase this, or we can look at more questions. So a very common question right now with the coronavirus vaccines is, does, I believe, the Johnson & Johnson vaccine increase the risk of blood clots? And we could rephrase that question. Would people have developed blood clots if they had not been given the vaccine? And that's an important question, because it's not as simple as just showing that, the vaccine and the blood clots are correlated, which we could find, but we could find that, yes, they're correlated, but it's not causal. And that's what the second question gets at. Would these people have developed blood clots if they had not been given the vaccine? Because some people maybe just were prone to blood clots and would have gotten blood clots anyway. Another kind of counterfactual question that's pretty important in the US right now that's being asked, I think, and it's hard to answer, is, if, we had reached our vaccination targets, would we have been hit as hard by the Delta variant? And that is a very, there's a causal question there. Would vaccination have prevented the amount of cases that we're seeing in the United States right now? And so, again, another question for you is to take the causal question, or the causal relationship that you were interested in for the previous question, and can you reframe it in terms of a counterfactual? And again, just you could drop these in chat if you like, or we'll just keep going. And yeah. So we're going to switch gears here, and instead of talking, in counterfactuals, we're going to think about how we can visualize these relationships, because again, I think the counterfactual question is really important. It's not always the most intuitive. So instead, what we want to do is visualize the relationships that we theorize to be causal. And we can do that using a directed acyclic graph. You'll hear, they're called DAGs. You'll sometimes hear them called causal diagrams or structural causal diagrams. They all kind of mean the same thing. There might be some slight variance, but DAGs. So in the simplest form, a DAG is a graph showing our exposure or our cause, and then showing an arrow pointing to the effect. So the exposure and the outcome, or the cause and the result, whatever you want to call it. There are some important things here, though. For instance, the arrow, in a DAG, they are directed. That means we have to show a relationship that has a direction. Unlike a correlation, which if we find a correlation, we might not be sure, what direction this relationship is going. In in a DAG, we are theorizing a causal relationship, and therefore we need to know, or at least theorize, we might not know, that one variable is causing the other. So again, this is a very simple form of this, if we believe this to be the true, relationship, let's say that we were testing, a very simple, two variable model should give us a correct, unbiased estimate of the actual strength of this cause on the effect. So if we had our model and we looked at, ambulances and dogs barking, and that was the only thing, there was no other variables that affected whether a dog barked or not. There was no other variables affecting, whether an ambulance was driving by or not. And we looked at this relationship, and put it in, let's say, like just a very simple regression model, that beta estimate should be a correct, unbiased estimate of the actual causal effect. But we're not usually that lucky. And so, I've got this question here, and again, feel free to put these in chat, but can you think of any situations that may bias the observed relationship between the ambulance and the dog barking? And to answer my own question, I'll give an example. I could think of, maybe there's something else that happened that caused both the ambulance to be in the area and the dog to bark. So an example of that might be, maybe there was a car crash right outside the house that night, and that is causing the ambulance to be in the area, and the dog started barking when it heard the crash. And so maybe we observed the ambulance causing the dog to bark, but in fact they're actually both barking because of the car crash. Robert says, someone knocking on the door as the ambulance drives by. Yeah, another example, like maybe there's just some other variable here that's causing the dog to bark, or maybe causing the dog to bark more. And that might bias the observed relationship a little bit. And that's going to be really important. We're going to talk more about different types of biases momentarily. But first, we're going to talk about making DAGs. I want this to be interactive. So we're going to talk about how we can make DAGs. So you can draw them by hand, or you can do them, in software that allows us to make diagrams. I think the Microsoft one's called Visio. There's diagram makers you can find online. But there are options specifically for DAGs that we can use. One of my favorites is Dagity, which you can go to by going to dagity.net. It's got 1 G and 2 T's. If you go here, you'll see a site that looks like this. You'll notice they have an R package. We'll get to that in a moment. But there's also like a visual editor that we can work with. So we're going to start here. They give you this kind of default example. We can go to model, to new model. And then this gives us a blank DAG. There's nothing in it yet, no variables. We can click and we can name our new variable. So let's do like colorectal cancer as our exposure. And so if we click on this variable now, we can label it our exposure. And then we can click again, just anywhere that's not on the variable, because that will just select it. But if we click anywhere else in this gray area, we should be able to enter something else. And so let's say like microbiome. So we're theorizing that this is my outcome, and we're theorizing that colorectal cancer causes some change to the microbiome. It might be a little more complicated than that. Of course, I know microbiome might cause colorectal cancer, which then causes changes in the microbiome, but we'll keep this simple. We'll just say this person got colorectal cancer, and then we can put an arrow to it to show that maybe it caused some dysbiosis or change in their gut microbiome. So we add that arrow by clicking on colorectal cancer and then clicking on microbiome. And so we've added this relationship here. So now what's really cool, what Dagity gives us is it tells us some things about our relationship here. So it tells us, do we need to adjust for anything to estimate the effect of colorectal cancer on microbiome? Right now, no, because we only have a 2-variable model. And then testable implications, it gives us this nice code that I will show in a moment that we can actually just copy and paste into R. And then it gives me a nice summary here of my exposure, my outcomes, any covariates, we haven't added any, and any causal paths. So we can think of some causal pathways or some possible other causal pathways that might cause, the microbiome to change. I think the most important probably in this relationship might be diet. We could imagine a situation where diet both has some causal implications for the microbiome. I think that's pretty well established. And that the diet also affects, whether a person develops colorectal cancer. And so now we've added this third variable, and we can see here things have changed. So it's red, and that means that if we wanted to estimate the effect of our exposure on our outcome, we would need to adjust for it. And it tells me as such on the right here. It says my minimal sufficient adjustment set is the variable diet. My model code is updated, and we can see here now that I've got a covariate added here. And so we can do this here. The cool thing about DAGD is we can take this code, we can go into R. Let me just make a new script here, and there is a package called DAGD. It's on the CRAN, and we can just, I believe we have to do single quotes. We can just put this model code in there. Oh, and I think we have to give it a plot. And we get this nice, it's exactly what I made in DAGD, not quite as colorful, but we get this, the diagram I just made. And then we can start futzing with it. We could play with the arrow sizes, we can add color, and we'll get to that momentarily. Just going back to my slides. So that's DAGD. I show another relationship, a more complicated relationship here using age, pollution, smoking as causes of lung cancer, as well as this kind of covariate genetics, which is what more or less what R.A. Fisher posited was the real cause of lung cancer among smokers. But this it's not the prettiest thing ever by default. Luckily, there's this great package again on the CRAN called GGDAG. And what that allows us to do is to clean up our DAG a bit and make it a little prettier, make the arrows stand out more, add some color to it. So I can save this object. We'll just call it DAG export. And then I can just make a GGDAG call. I can change things around and say, I want my nodes to be size 24. I want the text to be green. It's got some themes built into GGDAG that kind of turn off all the stuff that ggplot has with like X and Y axis labels and whatnot, which we don't really need. And once again, we get a nicer looking one. We could probably adjust the arrow size because it's very small, adjust the colors a bit. We could play around with this a lot, make something really beautiful. But just for the interest of the workshop, we'll keep moving. And so we have an exercise here. So make a DAG for a causal question of interest, then export it to R using DAGD and GGDAG, try adjusting different aspects of it. If you want to take a moment to play around with that, we can. I just want to be conscious of time. Let's see, we're about a third of the way in. Yeah, if you want to play around with DAGD real quick, well, I'll give you a minute. If you have any questions, now is a good time to slip those in the Q&A, or if not, I will move on after a few minutes. And again, the website is DAGITTY, DAGITTY.net. And then you'll click on launch DAGITTY online in your browser. You can make your own model by going to new model, or you can just take this existing one and try bringing it into R. So you'll just select the model code. You'll need to install the DAGD package, which is, again, just DAGTY. And then you'll do this DAGD command, paste that code in there as a string. Whoops. And then you can plot that object. So that's the default one that DAGD has. Q&A. Is there syntax for expressing uncertainty in DAG structure directionality? That's an excellent question, Michael. So one thing you can do in, I kind of didn't mention this, but in DAGD is you can actually put I believe you can change the direction of the arrow to be a double-headed arrow by, I think you just click on the two variables. So you click one direction and then you click the other direction, and then you get this double-headed arrow that expresses some degree of uncertainty. So we can add that, and then as you can see here in my model code, it then changes it to this double-headed arrow instead of a single-headed arrow, and that's used to express uncertainty. Ideally, when we theorize, a causal, diagram, ideally you should make I would say you should make a stance and choose, like, say, no, I'm pretty sure this causes this. But if you're really not sure, then I suppose you could use that, because as we will see in a moment, the direction of the arrows actually has some implications and for how we can adjust or deconfound for certain variables. But that's an excellent question. Yeah, seeing no other questions, I'm just going to keep moving forward. So that's how we make these diagrams. You can play around with them more, and it uses the ggdag, which is based on ggplot. So I think pretty much everything you can do to a ggplot, you can do to a ggdag. So you can spend hours playing around with them, futzing with it, getting it perfect, but we won't do that today. So again, so now we've discussed, kind of how we make these diagrams. So now let's talk about some sources of bias and confounding that we can actually see on these diagrams, and then how do we address them? So you've probably heard of confounding. I think, we're all introduced to it at some point probably, but confounding actually has a very specific definition, which we're not always exposed to as concretely. So we know a confounder it's a lurking third variable that can create bias in a relationship between two other variables. But there's actually a strict definition. The confounder has to cause the outcome, and it must cause the exposure. Now, it doesn't have to directly cause them. It could be, it could be down some kind of long causal pathway, but it does need to cause them. And it shouldn't be a mediator. That means it shouldn't be somewhere on the actual causal pathway between the exposure and outcome. So returning to our example of the ambulance and the dog barking, we can, as I mentioned, the car crash could possibly cause both. It could cause the ambulance to be in the area, and it could cause the dog to be barking. And so we can represent that in our DAG by adding this car crash. It causes the ambulance, so we see an arrow pointing from car crash to ambulance, and we see it pointing from car crash to dog barking. And so when we add a confounder to our model, when we consider the possibility of confounder, there is what's called the front door pathway. The front door pathway leading from ambulance to the dog barking is that relationship. But what a confounder does is it opens something called a backdoor pathway. And what this backdoor pathway is it's this pathway leading from ambulance through car crash to dog barking. And what that backdoor pathway does is it introduces bias. It could bias our relationship towards the null. We could see less of a relationship. It could also bias our relationship away from the null. We could see more of a relationship. So that is the case in this situation, where we might observe barking and conclude that it occurred due to the ambulance, when in fact it was mostly due to the car crash. Or we could think of an example where maybe a confounder that makes the relationship smaller than it would otherwise be. Maybe the car crash causes the person to bring the dog inside, and so as a result, the dog barks less at the ambulance than it would have. So it can bias the relationship either way. So my question for you is, what are some common confounders in bioinformatics or health research or your own research? And please feel free to put these in chat, because I think this is an important question to consider. It's like, what are some common confounders? Age, smoking, drinking. Yep, these are all very common. Access to healthcare, that's a great one. Some people have better access, and that can confound the outcomes we see for different health interventions based on access. Batch effects. Oh, that's a classic one. Yeah, batch effects. Oh, did my headset just turn off? Sorry, I'm having my headset just turned off for some reason. Can you hear me? Thumbs up if you can.
The audio is fine.
Okay, perfect. Thank you. Sorry, my headset has this auto off feature, and sometimes after half an hour, it just turns off. Okay, so ethnicity, yes, race, ethnicity, that's a huge one. Study site. Epigenetic regulation and gene expression, those could be confounders. I think gene expression could also be a mediator sometimes. It depends. And an important thing here is the answer, it depends, because you have to kind of theorize what your causal model looks like, and then imagine if that's a confounder, is it a causal variable for the exposure and the outcome, which is possible. So how do we address confounders? I mean, you've often probably heard of people controlling for a variable in a regression model. There's also the old-fashioned way of doing things, where you stratify by levels of a confounder, and then you kind of calculate a weighted average. This is just a point of trivia. I think some people still do a little stratification, but the more modern way would be adjusting for it or controlling for it in a regression model. Another term for this would be deconfounding. I like this term because it's inclusive of both, a stratification approach or, a controlling and regression model approach. And it sets, kind of the sights on what you're doing, what your purpose is here. You're not just, throwing this in the regression model because you feel like you're supposed to, but you are doing this for the purpose of deconfounding. And so what you can do if you're following along and making a DAG is using your DAG for this causal relationship of interest to you, consider potential confounders. And so in the example I gave above of smoking and lung cancer, we've got this confounder that R.A. Fisher posited of genetics, and we can see it both. He proposed it both cause smoking and cause lung cancer, and therefore was a causal variable or a confounding variable of this relationship between smoking and lung cancer. I added a few others. Age could possibly be a confounder because people may be smoking. If we imagine smoking as kind of more of like a dose response, so the amount of smoke that they have ingested as they have smoked, and then as you get older, you're just more likely to develop cancer through other pathways as well. Pollution maybe as a proxy for maybe like a socioeconomic factor. Maybe people who are more socioeconomically disadvantaged might be more likely to smoke and might be exposed to pollution. So that would be kind of a proxy for some kind of socioeconomic environment factor. And it's okay, if one of your variables that you adjust for is kind of a proxy variable in that way. It's not perfect. Obviously, in the ideal world, you would have perfect measurement of every possible confounder, but that's not really possible, as we know. So if you can find a good proxy, that and deconfound for that proxy, that will hopefully help you recover a good estimate of that causal effect, even without measuring the variable. As you might have heard previously, unmeasured confounding is kind of a big issue, and we'll talk about unmeasured confounding a little later. But if we don't measure it, we can't control for it or deconfound for it. Oh yeah, it's right here. So this is the biggest issue in observational research, is that there are confounders that we may not have measured, or they may be very difficult to measure. Socioeconomic factors can be very difficult. There's a lot of different things. Human beings can be very complicated, and it's very hard to disentangle that. Another common kind of form of unmeasured confounding is if we didn't measure the confounder at the complexity that we needed to. So something like diet can be very complicated. Even two people who follow, let's say, a very strict, keto diet can still just be eating very different foods, even as part of this same kind of strict diet. And so as a result, we've kind of got this difference, this unmeasured difference between these two people, even though they eat the same diet, but they have different foods, and that can cause some kind of unmeasured confounding. There is no perfect solution to unmeasured confounding. It's a missing data problem. We needed to collect these data, but we were unable to, or didn't for some reason. And so really the only solution that I'm aware of, once we've collected the data and are at the analysis stage, is to do some form of sensitivity analysis, where we simulate like an unmeasured confounder and see how it would affect the observed relationship between our exposure and outcome. So we see how sensitive it is to this unmeasured confounder, and then we can use that sensitivity analysis when we interpret our results. If we find that even a small unmeasured confounder can substantially change our results, then we would be very cautious. On the other hand, if we see that it takes a very strong unmeasured confounder to even just change our results slightly, then we can be more confident. And this is actually effectively what they did in the case of smoking and lung cancer. So again, R.A. Fisher posited this genetic factor, and given that it was the 1950s and 60s, they couldn't just do a GWAS and find, there's genetic factors and measure them. So what they did is they looked at, okay, if we had a hypothetical confounder of the relationship between smoking and lung cancer that was creating this relationship, how big of a confounder would it need to be? Like, what would the effect size have to be of that confounder on the exposure and the outcome? And they found it needed to have, it was something like an odds ratio of like 9 or something, or 10. So it would have to be just an absolutely extremely powerful confounder to create the observed relationship between smoking and lung cancer artificially. And so that made them more confident, even though they only had observational data, because they couldn't do an RCT. So that made them more confident in their results. So moving on to our next type of variable in these causal models, a collider. They look very similar to confounders. However, they are not common causes of the exposure and outcome. They are common effects of the exposure and the outcome. That is to say, the outcome causes the collider, the exposure causes the collider. Once again, the collider is not a mediator. So in our ambulance dog barking example, once again, we see that we've got a third variable, sleep disruption, but in this case, the arrows are pointing towards sleep disruption, as compared to my car crash example, which you can see the arrows are pointing towards the exposure and the outcome. Now, in this example, they're pointing towards sleep disruption. So this is a variable, this is another kind of third variable, but in this case, in this situation, again, the relationship between the exposure and the outcome, or the exposure in this collider is pointing the other way. And this is really important to try and distinguish between confounders and colliders, because if we deconfound for a collider, we're actually possibly introducing bias, because by adjusting for a collider or deconfounding, we're actually creating a backdoor pathway that where one didn't exist. So there is a property of DAGs, of these causal relationships, where if two arrows hit each other, that pathway is blocked. So in this case of this collider, these two arrows colliding in sleep disruption have blocked this backdoor pathway. But if we add sleep disruption to our model, we are now opening this backdoor pathway where one didn't exist. Again, I'm keeping that, you're going to have to take me on faith on this, but if you want, I will show you some resources at the end where you can see the actual math behind this, where they prove that colliders don't affect the relationship between exposure and outcome, except if you adjust for them. So what's the proper way of dealing with colliders? You can ignore them. You know, sleep disrupted, me waking up because the dog is barking, shouldn't really affect this relationship between the ambulance and the dog. So we can ignore that for now. Again, here I'm just explaining just the block pathways. And that entire pathway is blocked even if we have multiple variables in a pathway. If there's a blockage anywhere, that entire pathway is blocked. So if we had something here where we've got C1 and C2, but there is a block pathway between this pathway between C1, C2, and the outcome, that pathway is blocked. We wouldn't need to adjust for it or deconfound for it. So another exercise, using the DAG you made in exercises 1 and 2, if you've been following along, add a collider. If not, you know, we can add one here. So we could say, okay, well, possibly I'm going to say, like, maybe as a result of a person having colorectal cancer and having, you know, dysbiosis of the microbiome, maybe they're experiencing a lot of side effects and they're visiting their doctor more. And so maybe that is a collider in this relationship. And so you can see here, when I add this collider doctor visit to my model, it doesn't tell me I need to adjust for it. Because it's not a confounder, it's a collider. So we don't need to adjust for that to get the effect of colorectal cancer on the microbiome. So that's how you add a collider. Any questions so far? Any concerns? Give people a quick minute while I take a sip of tea. Cool. Oh, image didn't load. Okay. Let me pull up this image. So let's see if we can find a bigger version of it. This will work. So you may have seen this image before. Maybe not. But this was an image, I think it's probably been modified, but that came from a study done in World War II of airplanes. So I believe it was the British Air Force during World War II hired a statistician to help them improve their airplanes. And this statistician went and studied the airplanes that returned from, you know, missions where they had been shot at. And he made I guess you would call this maybe a map, a chart, a diagram of where all these planes had taken damage. And he found that planes, maybe this one's a little better. Yeah, this one's better. Planes that had taken damage in these areas had returned. And so he said, okay, well, these planes all returned. That means, at first they had thought like, okay, this is where they're taking damage. This is where we should add more armor. We should, improve the metal, make it thicker in these areas. But he said, no, it's just the opposite. The planes that don't return are the ones that take damage in these areas, the areas that don't have red dots. Because those areas, if they get damaged there, let's say on an engine, they crash. They don't come back. So we don't want to improve the areas where the planes return are taking damage. We want to improve these areas where we don't see the damage, because that means those planes did not survive long enough to get back to base for us to study them. This is a very famous example of survival bias. But what another term for this survival bias is selection bias. And this is a huge issue in causal inference. And it's one that we don't always think about as much, but it happens when we accidentally, not through any probably not on purpose, but we accidentally condition on a collider, or we accidentally, have some kind of collider, which we can call selection or survival. And we have accidentally opened this backdoor pathway through survival, just due to the nature of the way we've designed our study. Because, ideally, if we were doing this plane study and we wanted to not have selection bias, what would we do? Well, we would go into the field where the planes crashed and study where they took damage. But obviously, we can't do that during a war. So, that was the consequence of that. One of one of the faculty members I work with calls selection bias the already dead problem, which I always find to be the most kind of memorable way of remembering it. And it's effectively people who have already died of the outcome are not alive to be in our study. And these people may have had a more aggressive or serious form of the outcome, and then not including them masks some of the causal relationship. You may have also heard of this. It's sometimes called the healthy worker bias. You see this in occupational or environmental studies. Another famous example is coal mine workers. There were a lot of studies done of coal mine workers and mesothelioma, I think, is the disease that a lot of them get. And a lot of the coal mine industry did these studies, and they said, no, look, our workers are fine. None of them are sick. So even though they're getting a lot of exposure to coal dust, none of them are sick. And then the issue is that all the people who are sick have already quit. And so you would create this healthy worker bias where you observe, all my workers are healthy. They must not be getting anything from this coal dust. But in fact, the workers who are getting sick from the coal dust have already left the job and therefore are not included in the study. So that's healthy worker bias. It's just another form of selection bias. You've accidentally conditioned on a collider of some kind of selection or survival. Another form of selection bias is loss to follow-up. Let's see, Darren says, selection bias can cause one to overestimate prevalence of missense mutations in genetic disease if the LOF mutation subjects died too early in study. Yeah, I think that's a good example as well, in kind of a genetic example. And it could be true that there's some genetic factor where if people have, some kind of serious variant, they die of it and don't survive long enough to be in the study. Another common form of selection bias is loss to follow-up. This is particularly important for RCTs in that if you are giving participants some kind of drug, it's possible that people who have very severe side effects or the drug isn't working for, they drop out of the study and they're lost. It's also very possible in observational studies that are longitudinal that people just drop out of the study, and maybe those people differ in some way from people who completed the study. And this could introduce selection bias. Unfortunately, again, because we're losing these people. This is another kind of missing data problem, and it's very difficult to assess how people who are lost, how do we account for selection bias? Ideally, at the study design phase, we try and design our study in such a way to account for selection bias. There have been some studies I've seen where they actually make an active effort using, like basically the white pages. They look up participants they lost and try and find out what happened to them. I think the NIH even offers like a death database where you can look up if participants have died and that's how you lost them. So there's a few different things you can try and do, but all of these are kind of trying to solve a pretty difficult problem. So my question for you all to consider is the collider you added in exercise 3 a possible source of selection bias? If so, how? So looking at the DAG I've made where I added kind of visiting the doctor, maybe if my study design was based on people who are visiting the doctor's office, maybe people with the most severe colorectal cancer are dying, or maybe they're going into hospitals for long-term care, maybe something of that nature. And if I'm only assessing them because they come into my outpatient clinic, possibly that could create some selection bias where I'm missing out on people with the most aggressive forms of colorectal cancer. So that's a possible collider in this model, or possible source of selection bias. So that's colliders. So I've talked a bit about study designs. I want to just go very briefly through them, and some of the causal implications of different study designs, because I think it's important to consider how different study designs affect how we answer causal questions. Probably the one that I'm guessing the people here are most familiar with will be randomized control trials or randomized clinical trials. We all know the exposure of interest is assigned at random. We know that's pretty important for answering causal questions. Why that is important from a DAG perspective is because the exposure is assigned at random, there are no possible confounders of the relationship between exposure and outcome. So looking at my DAG, let's assume we're super unethical and we're able to assign colorectal cancer to at random. We pull people in and point at them and say, you're going to get colorectal cancer. Well, because that's assigned at random, this arrow between diet and colorectal cancer can't exist. There can't be anything that causes a person to have colorectal cancer in this example where I've assigned it at random. And so we know that there are no possible confounders if we've randomized correctly. And as a result, because there's no possible confounders, this is considered the gold standard for causal inference. However, selection bias is still possible. So I'm going to turn this question over to the chat. How can selection bias occur in an RCT? I think I just mentioned it, but this is more a test to see if you're paying attention. Any thoughts? Yep. Thank you, Andrew. Andrew says losses to follow up after randomization. Yep, perfect. So yeah, if we lose people differentially between exposure groups, especially like, again, if they don't tolerate the exposure or the new drug or whatever you're trying, and they drop out, or possibly your study, like you're not able to assess whether they've died or not, that could introduce selection bias in an RCT. So even though this is the gold standard, there's still possible sources of bias is the important point here. Another common, study design we see in bioinformatics would be like Mendelian randomization. Mendelian randomization is actually the same thing as instrumental variable analysis, which is used in economics a lot. And this attempts to mimic an RCT using some kind of pseudo randomization source. So we can imagine we've got like an RCT basically looks like this. We've got some kind of coin flip that assigns an exposure, which then we assess for an outcome. And so because we've used this coin flip as a randomizer for the exposure, there's no possible confounders. And so in a Mendelian randomization, we're doing the same thing. We've got some kind of genetic variant that is causing an exposure, and then we assess an outcome. And therefore, hopefully, if that confounder does not confound the genetic variant as well, this genetic variant will then be a kind of a proxy for an RCT. And again, this is a very simple form of this. I know MR is very complicated. I actually just TA'd a long workshop on MR, so I'm just giving you a bird's eye view. You can also use other instrumental variables as well. You'll see these in public health and epidemiology studies. You'll see before and after implementation of a new government policy, distance from a medical center, or access to medical treatments, genetic variants again. I think we look at this, and often the question comes up like, why don't we just do instrumental variable or Mendelian randomization studies for everything if they allow us to make an argument similar to an RCT instead of doing observational studies? But again, I'm going to turn this over to chat. What might be some issues with doing like a Mendelian randomization or an instrumental variable study? Give people 1 minute. Yep, Michael got it. Not truly randomly assigned. Finding a true instrument or a true variable to take the place of this coin flip can be very difficult. Or if the genetic instrument causes many things to happen. Yes, so I believe that's called like horizontal pleiotropy, where the genetic variant might have some other pathway to the outcome. So these aren't perfect. There can be limitations, and that's why we have some observational studies, which I'll mention real quick. So we've got cohort studies. These are where participants are chosen on a common characteristic and followed over time. The most famous of these might be the Framingham Heart Study, which is the participants are everyone living in the town of Framingham, Massachusetts, and they followed up with them over time to see, and by over time, I mean over the course of decades. So sometimes these studies go on for a long time to see the health outcomes that they developed. But because this is an observational study, selection bias and confounding can occur. Another common type is case control studies, where we choose cases, people who have a condition of interest, and then we try and match them to people who are very similar. And once again, there can be selection bias and confounding. We've got a question. In longitudinal data analysis, we sometimes can assume a model for the missingness. For MCAR, missing completely at random, there's also missing at random or missing not at random. Can these assumptions also help in causal inference settings? That's a good question. So I didn't want to get into too much jargon around missingness, but yeah, so unmeasured confounding is actually just another term for missing not at random or not missing at random. I believe theoretically they are functionally identical. There's a lurking variable that is causing bias that we have not measured. And so missing not at random and unmeasured confounding are effectively the same thing, just different terms. However, if there's missing at random or missing completely at random, there are techniques for addressing those. And so using those techniques such as multiple imputation, you can do those in the context of causal inference to account for sources of like measurement bias or missing data issues. They can help with those. Yes, good. That's an excellent question. Cool. So rather than just talk at you this whole time, I did want to show that, there are some things we can do in R to help with causal inference. It is, based on our understanding and theory. Again, I introduced DAGs. We can do complicated relationships in it. Here is code. I just include this, but you can get the same thing from DAGD and GGDAG that will show us what we need to adjust for, even in complicated situations. And so what's nice is that we can make a very complicated DAG, because as we know, often with health issues, the relationship is rarely just 3 variables. It's usually, just conservatively, it can be dozens of variables. And it can be very complicated, looking at this. If I want to say, okay, what do I need to adjust for to find the effect of X on Y? It might not be immediately obvious to you, but it is obvious to a computer. So we can actually tell it using this snippet of code here. And it will give me the adjustment sets. So it will tell me, every possible thing I can adjust for, but we can say the total effect of X on Y is identifiable controlling for any of these sets. So you can adjust for this one, or this one, or this one, or this one. So there's multiple ways to adjust for it to get the effect of X on Y. GGDAG, we don't have to use this code block. GGDAG can actually just give us an adjustment set, and I can, just by using this GGDAG adjustment set, so I can show this real quick, adjustment set using, oh, headset is being weird again. Okay,
Sound is fine.
headset is being weird again. So in this case, let's say A and let's say Z. In this case, we wouldn't need to adjust for anything in this relationship. But let's pull a more interesting example in. So let me pull this one in. Oh, I've got to change my variable names. So colorectal cancer is my exposure. Microbiome is my outcome. Now we get something interesting. So we can see here, again, it tells us, oh, we probably need to change the text color, but colorectal cancer, which is here, microbiome, we don't need to adjust for doctor visit, it's blue, but we do need to adjust to diet, it's red. And so that gives us that. Seems pretty straightforward with this, but again, imagine you had a lot more variables. So here's that example using this chart up above of the different adjustment sets. So it tells you, here's what you can adjust for, and it gives you 4 different diagrams of how you can adjust for it. So adjusting for confounders, we can do that for our analysis. DE-seq2, EdgeR, limma, they all have ways of adjusting for confounders by including that as a covariate in our model. We'll do an example using DE-seq2 in a moment, which, yeah, we'll get to now. Any questions before we go into the example of just build? So in this example, we'll start with it by building our DAG, downloading the data, looking at our condition of interest, running them, and then running the models. Any questions before I move on to this? Okay, well, we'll move on. So we're going to be using curated metagenomic data, which has a bunch of microbiome data sets ready for analyses, which is convenient for our purposes. The data set has 50, the specific data set we'll be using is this Folkman 2016 data set. It has 52 cases of colorectal cancer and 52 controls. And so step by step, we're going to think about what would the DAG be for this relationship between colorectal cancer and microbiome. I've already kind of started thinking about this. Then I'm going to download the data, look at the study condition, remove any missing values. We'll start by running a bivariate model just to see, without any controlling for anything, what does it look like, and what taxa are significant. And then we're going to deconfound by adding some variables. So all of this is in the workshop, so you can follow along. I might switch to R for some parts of it, but first we'll start by drawing our DAG. So again, I can go into here. I've got this model I started. I could say, diet. Some other ones might be, age. That probably could confound. Your microbiome changes as you get older. It could also, you're more likely to develop cancer as you get older. You could say gender or sex. There are sex-specific differences. I think men are more likely to get colorectal cancer, and microbiome can vary based on sex or gender. And we can imagine some others. I think diet is important. We could imagine there might be some, like other socioeconomic indicators. There could be like, some kind of income SES indicator that might affect both. This is getting, let me move these down so that I can just put everything so it looks nice and neat. So we could probably come up with 5 or 6 more variables just off the top of our heads that could possibly confound this relationship. We could also think of some colliders that could maybe cause selection bias depending on how the study was done. I think this is just a case control study that was done in either a hospital or outpatient context. So now that we've made our DAG, then we can think about, okay, what data do I have? There's another example making my DAG. In this case, I kept it simpler and used just gender and age. We can check what I need to adjust for. Again, DAGity will tell me that up here. I can also get R to tell me that using the ggDAG adjustment set. So age and gender. And now we can start working with the data. We know what we need to adjust for. I won't belabor this point too much because I think that we know what we need to adjust for, and we if you use DEC, you know how this works. One thing to note is curated metagenomic data is actually, it gives you a tree summarized experiment now. It's no longer an expression set. But we download the data from curated metagenomic data. We filter out anyone who's missing a study condition. And we can look at this table of study conditions. So as I said, we've got 52 controls and 52 cases of colorectal cancer. Once again, we can run our analyses. So we convert it to a DESeq object. I kind of did this the long way around. You don't have to turn it into a phyloseq and then into a DESeq object. I think you can just directly take a summarized experiment and turn it into a DESeq object. I just know Michael is hosting, so I don't want to mislead people about how to get stuff ready for DESeq. Then we can take our results we can run our model. So we can see here our model is just using no judgment. Thank you, Michael. It's just using study condition for now. So we specified our model of study condition. We fit our model. Again, I think if this were, since this is microbiome data, you'd probably use like a different fit type, maybe a negative binomial fit type of some sort. And I'm guessing a likelihood ratio test would probably be better, but I was just keeping things simple. And then we can get our results, apply some level of significance. I kept it pretty broad here, and then, find which results were actually significant and get a significance table. So I ran this this morning in R. We end up with 172 significant results. Some of them, I think there needs to be some cleaning. I'm guessing what's happening with these astronomical fold changes is that it's present in one of the cases and maybe not present in any of the controls. So I might do some additional work on this, because I'm guessing these are not really things that, I don't know, I'm a little interested in why these are so significant, but and have such a large fold change. But the point is, we've done this very basic analysis. We can then this is too long. I need to fix this. Next, we can add in one of our confounders and deconfound for it. So we just add age. We're using a categorized age as a side note. Age, I'm a big fan of keeping ages continuous and then just adding an age squared term. But again, keeping it simple and adding a categorical age to our model. Running the same process again, and we get slightly different results this time. We can run it here, so you can see what this actually looks like. This down a little bit. It takes a moment to run because we've got a lot of different taxa, but the important part is that we get 175. So actually what happened was that age was actually, masking potentially some of the significant results. So we actually have 3 more significant results that maybe were due to confounding we wouldn't have observed in just looking at study condition. And then finally, we can add in gender, again, just adding it as a covariate in our model, and once again running it and getting 8 more significant results. So it appears that confounding by gender was masking even more of our results. And that's important because confounders, can bias our results either towards the null or away from the null. And in this case, it seems they were biasing them towards the null. And it's important to know potentially that we've got some microbiota that, some taxa that were not significant in just the study condition model, but once you deconfounded are significant. So yeah, I these big printout things I fixed, but are not present in the website version yet. So we have deconfounded for age and gender, and we found that colorectal cancer is associated with increased abundance of, this should be 185 taxa. But we would probably still hesitate to argue that this is, necessarily a causal relationship. What are some sources of bias that might still potentially affect our model? And how could we design a better study to account for these biases? And this is a question for chat. Well, I'll get started by doing the low-hanging fruit of selection bias. Levi says, if microbiome is instead a mediator of the effects of diet, SESX, how could the mistake in the DAG affect the estimates you made with diet and SES as hypothesized confounders? Planted question. Thanks, Levi. Yeah, if microbiome is instead a mediator of the effects, that is to say that the arrows point, in the opposite direction. So let's say, we've got a mediator of the effects of diet and SESS. So if the arrow was pointing that way instead, where microbiome affects their diet, maybe they get an upset tummy if they eat certain foods because of the condition of their microbiome. And we adjust for that. We are, in effect, maybe potentially masking some of the relationship between the exposure and the outcome because we have adjusted for something that was not a confounder, and we've adjusted for maybe some of the potential pathway. Yeah, that's a short answer to that question. It kind of depends. It is a little weird because microbiome is the outcome here. Reconfounders, treatments for colorectal cancer. Yes, treatment is a great one that could be a confounder here as well. Yeah, so, and some other sources of bias in this example could be selection bias, and unmeasured confounding or confounders I didn't adjust for. And how could we design a better study to account for these biases? I mean, the most important one would be trying to measure all the potential confounders that we can think of. Maybe for selection bias, recruiting participants at time of diagnosis. I'm not exactly sure when participants were recruited for this, but at time of diagnosis, potentially. Yeah, so got a few more discussion questions in our last few minutes here. So my first one is, often in our work, we are presented with data that have already been collected and we are asked to analyze it. Sometimes, if we're lucky, we have the privilege of designing a study from scratch. And sometimes we are brought in when analyses are done for a paper, basically, and just asked to give our feedback. When during the study process should we start considering the causal relationship and create a DAG? And is it too late to make a DAG if the analyses are nearly completed? And again, just put your answers in the chat. If it was too late, we'd be out of a job completely. And if the analysis is nearly completed, but you did it wrong, then it's not nearly completed. I like that. That's a good point. Unfortunately, sometimes, you know, with your co-authors telling them if you did this wrong, go back to square one does not always work out as well as you would hope. Yeah, there's a good answer from Andrew. You could describe the DAG that would make the analysis as completed valid. So yeah, that's a good way of thinking. Like, even if we're at this phase at, you know, nearly finished of our analyses, it's still helpful to make a quick DAG. You know, often what I do is I create a DAG of the relationship that they tested, and then I'll create, you know, like my DAG based on what I know from, you know, previous, you know, research and from other, you know, just from my experience in the field or on that topic, what I think the DAG should look like. And then I try and see, like, how different are they? Is there a way we can make, you know, the DAG of what they actually did look more like the DAG of what I think they should have done? Like, is there a few variables they could adjust for? Is there a type of, you know, sensitivity analysis they could do for these variables that maybe weren't measured, or for selection bias, you know? And it sometimes it can be a hard sell, but often I think it's telling people that this will make your paper stronger. Yeah, I don't think it's ever too late to make a DAG. I sometimes, even when I'm reading other people's papers, will make a DAG, and that really helps me in understanding, okay, this is the question they were trying to answer. This is the relationship they were interested in. So I think DAGs are appropriate to make at any point, and they can always be a very helpful tool in understanding the causal relationship that they were actually exploring. One important subject that I didn't touch on was generalizability or transportability of causal findings. That is, you know, we do this study in maybe like a lab setting or a very controlled setting with a specific population, and then we want to take those results and apply it to an external population, maybe a population in a different hospital system or in a different country. What issues might arise when doing so, and how may we use a DAG to resolve issues of generalizability and transportability? again, put those answers in chat. This one is a tough one. I think I think about this one a fair bit, and it's not the easiest question to answer. So don't be afraid to just throw out what comes to mind. Mike says the DAG made for the study population might not be applicable for the generalized population. If you studied non-smoking non-pregnant people, it's good to know that in DAG form before generalizability. Michael says, thinking about RCT cohorts being optimized and how the variables used to optimize the population would fit into a DAG for outcomes. These are both, very good points. If you do this study in non-smoking, non-pregnant people, there might be some assumptions you've made, and you can encode those assumptions in your DAG, and know, that there's possibility that smoking probably matters. And so maybe if I did this whole study in non-smokers, but I know, smoking probably has an effect here, I could then say, okay, well, I know my effect in non-smokers, but now that I'm trying to apply these findings to a general population, they could change because of smoking, and I need to be aware of that. Andrew asks, can we express this using a model of conditional causality where E causes O only when Z is greater than 0? Is Z a mediator in this case? You could call this, you could call your results like a conditional model where it's conditioned on a certain third variable, like let's say smoking being equal to 0 or equal to 1, and say, I know this effect is true given that condition. I don't know what the effect will be if that condition changes. Z is a mediator. Is Z a mediator in this case? I don't think it has to be. It could be a confounder. It's possible. Yeah, it could be a mediator in that it changes the effect. It depends. I guess it depends on your DAG. It's a good question. I'll have to think about that a lot more, though. So some really excellent thoughts. Thank you all so much for those. I just want to wrap up since we have about a little more than 5 minutes. I do wish I could come in here and just tell you, here is the answer in R and Bioconductor to causal inference. Here is how you achieve perfect causal inference. Unfortunately, I can't really do that. So instead, we have to rely on our knowledge, our expertise as researchers and scientists to consider possible sources of bias in our studies. And hopefully, ideally, we can do that at the beginning of the study when we're designing the study, but this is useful at any point. These DAGs are helpful in providing a clear visualization of a hypothesized causal mechanism, identifying potential sources of bias. One very famous epidemiologist, Miguel Hernan, says of DAGs, draw your assumptions before you draw your conclusions. I really like that motto of the DAG helping you along the way to making conclusions. And it's a helpful tool in that regard. As mentioned, unmeasured confounding is just, it's a missing data problem, and it's difficult, and it really affects observational studies, which is why RCTs are so useful, because if randomized correctly, there's no possibility for confounding. Finally, just a reminder that the definition of a cause will be rooted in that counterfactual. And so we need to find a way to come as close to observing what would have happened if exposure status had been different, which is not always, which is not usually possible. So we have to find a way to mimic that as best we can. Finally, I want to recommend some more reading. This was a very basic introduction and workshop, but if you want to learn more, I highly recommend Pearl and Mackenzie's Book of Why, which is the new science, or subtitled The New Science of Causal Effect. It's written as kind of a mass market science read, so it's really easy to read. It's fun. They use a lot of great examples, including some that I pulled into this workshop. But if you've ever, it's super great. It's an easy read. And if you've ever wanted to know how the multi-hull problem works from a causal inference perspective, the Book of Why will teach you that. There's also, if you want something a little more academic, there's Hernan and Robin's causal inference textbook, which is free and available online on their website. So you can download the entire book. This book is great. It gets into a lot of the math and theory behind a lot of the stuff that I was telling you about today, about causal effects, conditional, like independence in terms of confounders, that sort of thing. But it's a lot more detail. And then it goes into some more advanced methods that I didn't have time to talk about, such as G estimation, structural models, and that sort of thing. It's a great book. I highly recommend it. If you really want to get into the weeds, Pearl has a book called Causality, Models, Reasoning, and Inference. Pearl is a computer scientist, and this book is, from my perspective, it is a very difficult book to get into, but if you're all about understanding the math behind it, that is a great book to check out. And finally, there is an edX course that Hernan did, which you can access freely, that teaches you a lot more about causal diagrams, about DAGs. And there is a paid version, but there's a free version as well. So thank you so much to everyone who attended. If you have any questions, we've got about 3 minutes left. I'm happy to answer them.
Thanks for the great workshop, by the way.
Thank you.
It looks like you knocked out all the questions during the session.
Fair enough. Yeah. If anyone thinks of anything, my email address is at the top of the workshop. If you have any thoughts, questions, feel free to email me. I love thinking and talking about this stuff. So I'm happy to help. Another thing I'll point people to, if you, in the workshop, there's some questions that I got at last year's talk, and I added my answers to those questions that I got in some detail with some DAGs. So yeah, and if you have any other questions, comments, thank you all so much.
Perfect. So thank you again. And just as a reminder, we'll take a break now, and then at noon, sorry, I'm on East Coast time. In a half hour, let's say, there's the opening remarks and the first keynote by Daniela Witten. Okay, so I guess I'll close the session for now.